screen.
Good evening, everyone. So today we are here for the sixth presentation of the basic module of Critical Care Medicine Forum. So today's topic is obstructive shock. So we had earlier seen the previous types of shock, the how different types of shock differentiate among themselves. We saw septic shock, cardiogenic shock, and today's topic is obstructive shock by Dr. Sri Vishwapal. So let me tell you about something about Vishwapal. So he is a team leader in critical care clinical pharmacist at Sri Ramakrishna Hospital. He has completed his antimicrobial stewardship program from the OSS Health Group. He was also invited as a speaker at PsychoCon in 2023. So before we start and go ahead with the presentation, we have some participant guidelines. So you can ask the questions related to the presentation, and those will be discussed at the end of the presentation. You can type on the chat box or the comment box in the YouTube. The participant guidelines further, the feedback, it will be a great thing if you could provide us feedback, which will be disabled after the live session. The certificate will be provided to all the attenders, which will be issued within 14 days after attending the event. If you're watching the event on YouTube, please log in. Just a second. And you'll be able to download the sites from the website, and login is mandatory to download this file. Yeah. You can go ahead with the presentation. Vishwa. Thank you.
Thank you, sir. Thank you for the wonderful introduction. So, good evening, everyone. And here I'm Vishwapal, Sri Vishwapal. We'll just see about what is obstructive shock today. So, before moving on to obstructive shock, I just wanted to say that I don't have any disclosures. So today's learning objective is something which is so we'll see what is a shock in overview. So as in the previous basic modules, everything has the shock has been covered, and we'll move on, and then we'll see what some few terminologies in cardiac function, and we'll see what is the difference between cardiogenic versus obstructive shock, and we'll see what are different types of obstructive shock and its management. So mainly we'll focus on pulmonary edema. So from the clinical pharmacist point, we have to make sure that there is something we got a role in the pulmonary edema management, pulmonary emboli management. So the first one is shock. Yeah. So what is shock? So shock is something where there is an inadequate or poor perfusion of oxygen to the organs or a tissue. So when there's a poor perfusion, slowly the organ or a tissue starts deteriorating, and one point of time it gets it loses its life and it dies. So a shock is differentiated into shock is classified into anaphylactic, septic, cardiogenic, and obstructive shock. So the other three shocks like anaphylactic, septic, and cardiogenic shock has been discussed in the previous basic module. So now we'll see what is obstructive shock. So before moving, I just wanted to have an quick intro between what is cardiogenic and obstructive shock. So just consider you as a cardiovascular system. So when you have a personal problem or when you have a problem within yourself, you get annoyed, you get agitated. So that is cardiogenic shock. But if a problem for you arises from the other person, from an external source, that is an obstructive shock. So cardiogenic shock is something which is confined only to the myocardium or cardiovascular system. But obstructive shock is something which is an external force which applies the force into the cardiac function, and it shows the altered cardiac functions. So the symptoms of cardiogenic shock is agitation, disturbed consciousness, cold extremities, and oliguria. But in obstructive shock, the symptoms are tachycardia, tachypnea, oliguria, and altered sensorium. So the differentiating these two in the diagnosis is very much important for all the healthcare professions for the proper management. So we got three types of obstructive shock. The first one is cardiac tamponade. The second one is pneumothorax, and third one is pulmonary emboli. So in pulmonary embolism, we will see detail about all the management. But in the cardiac tamponade pneumothorax, there is no pharmacological management therapies. So we'll move on to some cardiac terminology. So yeah, I'll just tell a brief about these terminologies. So the first one is cardiac output. So cardiac output is defined as something which is a multiplication of heart rate into stroke volume, right? So heart rate is when the heart rate increases, the cardiac output will automatically increase. When if the stroke volume increases, the cardiac output will increase. Okay, so we know what is heart rate. Heart rate is a beats per minute. So it is around 70 beats per minute is the normal heart rate which has been published. Okay, and a stroke volume which is equal to a difference between a end diastolic volume and a end systolic volume. So which can also be termed as preload versus preload minus afterload. So what is preload? The preload is something where the volume of the ventricles before systole, before the contraction is the preload, and volume of afterload is something where the volume which is present in the ventricles after after the contraction is the afterload. So difference between these two is termed as a stroke volume. So if the end diastolic volume increases, for example, if an end diastolic volume increases, stroke volume increases. So if the stroke volume increases, what happens? The cardiac output will increase. If the end diastolic volume or end systolic volume decreases, stroke volume will decrease. When the stroke volume decreases, what happens? Again, to the first formula, cardiac output will also decrease. Okay, so the next formula we'll see about what is mean arterial pressure, which is termed as MAP. So MAP is something which is a multiplication of cardiac output and the peripheral vascular resistance. So we know what is cardiac output, but we'll just see what is peripheral vascular resistance. Okay, so the peripheral vascular resistance is something where the resistance created when the blood flows through the arteries or a vein. Okay, so what happens in a peripheral vascular resistance? So how will you determine it is what the next line says. The peripheral vascular resistance is indirectly proportional to the radius of the vessel. So when your blood vessel is dilated, the radius is increased, so the peripheral vascular resistance will decrease. If the radius of the vessel is if the radius of the vessel decreases, means if there is any occlusion or contraction in the blood vessel, the peripheral vascular resistance will increase. So this is a scenario. So if the radius of the vessel decreases because of any occlusion or contraction, peripheral vascular resistance automatically get increases. When the peripheral vascular resistance increases, the mean arterial pressure increases. Okay, so we'll just use these terminologies in the further slides. Fine. So we'll move on to a case. Okay, Mr. Cleve is one of my friend, and he's very good guy. He is a 60-year-old male, and he was presented in the ER with complaints of shortness of breath, chest pain, and tachycardia. While he had this left knee osteoarthritis 5 months back, and he was done with the surgical procedure called left total knee replacement was being done 5 months back, and he is also a chronic kidney disease patient, CKD patient. He haven't mobilized previously. In the after the surgery, he haven't mobilized, and the social history also shows he's a smoker. Okay, so in the ER when they check for the vitals, the heart rate was about 140 beats per minute, and the BP was around 130 per 80 mmHg. So after seeing this complaints and the medical history, the physician directly ordered to add a confusion and order VQ scan, ventilator scintigraphy scan, and the results as we'll discuss about the results in the upcoming slide. So what do you guess? What would be the diagnosis for this patient? Okay, so whether it is a pulmonary edema or myocardial infarction or ARDS or it's a pulmonary embolism. So yeah, so just keep your answers with you. So we'll discuss what is the diagnosis in the later stage. Okay, fine. So yeah, so now we'll move on to what is cardiac tamponade. Okay, so as I said before, you are an you consider you as an heart. Okay, so if you are an heart, some external force is pushing you, so that you so that for example, you got only one bed where only one can sleep, and that too it's your bed, you are going to sleep. You have another person in your room who doesn't have a bed, he wanted to come and sleep in your same bed. Okay, so what happens, the amount of area which one bed contain is only for you. If another person comes, there would be some kind of congestion, or congestion between you two. Okay, so that's what the obstructive shock totally means about. Okay, so in this cardiac tamponade, where the heart is present in the pericardial sac, so if there is any kind of inflammation or a fluid in the pericardium, the pericardial sac will dilate. So what happens is it takes the place of the right ventricles and left ventricle. So what happens, then the right ventricle diastolic and systolic will be affected, and this will decreases the cardiac output, and so the patient might go for obstructive shock. So this is what about the cardiac tamponade says. So the main treatment in cardiac tamponade is pericardiocentesis. It is a life-saving procedure of choice in cardiac tamponade and can safely done in the bedside through echo. And the next one is tension pneumothorax. For an instance, we'll just have an example where you got hit by a car or hit by someone in your thoracic area. So you you try, so your breathing difficulty pattern has been changed because of the trauma which has been act in your uh, trauma in your thoracic area. Okay, so suddenly what the doctor does, he does so he just look for your proper oxygen status, for a proper breathing status, and he just he, he decompresses the area through a needle. This thing you could have seen in the Grey's Anatomy. So one of the episode they have shown that in an accident, a doctor comes, she diagnoses what is she had a proper diagnosis, and he suddenly wants a needle, and she just decompresses the thoracic area so that the air comes out. Okay, so that is what pneumothorax means. So accumulation of air in the pleural sac. So when the air gets accumulated in the pleural sac, the tension in your the lung will increases. When the tension in your lung increases, it also wants to occupy the space in the heart, so that there's a congestion in the heart, and again the heart doesn't have a breathing space for its contraction and dilation. The systole and diastole is affected. So the proper treatment is emergent needle decompression, and definitive treatment is thoracectomy tube placement in your chest area. And finally, yeah, so the next one is pulmonary embolism. So this is this area where the clinical pharmacist plays a major role. And yeah, so epidemiology, there's a 10% of all patients with acute PE die during first 1 to 3 months after diagnosing of PE, and 1% of patients admitted into a hospital die of acute PE, and 10% of all hospital deaths are uh, pulmonary embolism related, and 42 million deaths over 20 years has been recorded because of the PE. Yeah. So before moving to mechanism of action, just wanted to start with the Witch's triad. I guess most of us will be knowing what is this Witch's triad. So this Witch's triad is comprises of three factors. The one is the first one. You could see here the patient is in the lying position. This is the stasis of the blood. So if there is no movement or any stasis of the blood occurs in your body, mainly in your lower extremities, the blood starts to clot. It forms a thrombus. And the second one over here, you could see the RBC kind of cells. Okay, so this is an hypercoagulable stage. This is mainly in the this we could explain mainly through pregnancy and in the cancer types. So where there is an increased hypercoagulation, so the blood gets clot. and you could see a surgeon doing a surgery for a patient, and even this is an major problem, mainly if the surgery involves the lower extremity. So these three factors together can cause, or separately they can cause thrombus. Once when the thrombus, when it gets ruptured and forms emboli, this goes to the heart and causes pulmonary embolism. Okay, so we'll see the etiology. So the etiologies, based on the triad, which of triad, the etiologies has also been classified. The first one is surgeries, trauma, and immobilization, which can lead to pulmonary embolism, cancers, hypercoagulable state, oral contraceptives, infection, and other common risk factors include smoking, obesity, hypercholesterolemia, hypertension, and diabetes mellitus. So how does a patient presents in the ER or in a OPD with the pulmonary embolism? He or she presents with the pleuritic chest pain, dyspnea, tachypnea, hematosis, signs of DVT, and some scenarios, some situations, it's a rare situation where unless until it's an emergency or high risk, a patient doesn't feel comes with hypotension or tachycardia. Okay. So here comes the real pathophysiology. So we saw how the emboli, how the thrombus forms and how it comes as an emboli. So in acute pulmonary embolism, the pulmonary arterial bed gets occluded by the thromboemboli. Okay. So when the pulmonary arterial bed is occluded, as I said in the cardiology term slide, the radius of the blood vessel gets occluded. So when the radius gets occluded, when the radius reduces because of the occlusion, peripheral vascular resistance increases. So once when the peripheral vascular resistance increases, the right ventricle tries to it tries to maximize to increase the preload. So it tries to maximize for a systole, but it can't able to push the blood through arterial pulmonary arterial vein. So what happens? The preload increases. When the preload increases, pulmonary arterial hypertension increases. So when this happens, right ventricles gets dilated. So once when the right ventricle dilates, it increases the myocyte stretch and wall tension. So when right ventricle dilates, it needs space to occupy in your body, right? So what it does is it pushes the neighboring left ventricle. So left ventricle diastole will be soon. It is the left ventricle will contract very far in a faster rate. So there is a desynchronizing in the ventricle. So what happens? The right bundle branch get blocked, and the left ventricle preload decreases. So when the left ventricle preload decreases, cardiac output decreases. When cardiac output decreases, it leads to systemic hypotension and hemodynamic instability. Okay, so this is a small representation of pulmonary embolism. Hope everyone understood the pulmonary embolism. So here what happens is RV gets dilated. When RV is dilated, tricuspid wall sufficiency of regurgitation will decrease. So when it decreases, RV wall tension increases. When RV wall tension increases, it leads to myocardial inflammation. When there's a myocardial inflammation, the perfusion rate in the right ventricle will decrease. When in the right ventricle will decrease. So meanwhile, the contractility will decrease. When the contractility decreases, our right ventricle output will also decreases, and because of right ventricle dilation, left ventricle's preload will be decreased. When left ventricle preload decreases, cardiac output decreases, systemic blood pressure will decrease, perfusion of through right ventricle decreases, and so the obstructive shock occurs. So once when this obstructive shock is not treated, the patient will ultimately will die. Okay, so yeah, so we'll move on to the treatment protocol now. So our Mr. Cleve, as we know, he just came with those complaints, so we'll just have a proper treatment protocol for him. So the first treatment protocol, what it says is, if the patient is clinically stable or unstable. Looks like Cleve is stable, right? So okay, so now the looks like Mr. Cleve is stable, so we'll just have to do CT pulmonary angiogram. If the patient is not stable, we have to go for Wells criteria. So Wells criteria consists of three parameters. That is less than 4, 5 or 6, and more than 7. So here's the Wells criteria. So we have different a different test to estimate the Wells criteria. One is clinical signs, another is alternative diagnosis, heart rate if it's more than 100, immobilization if the patient is not immobilized for 4 days at least, previously any history of DVT or PV, hematopoiesis or any kind of malignancy which has been treated in the last 6 months. Okay. Um, so now Mr. Cleve was presented with shortness of breath, chest pain, and tachycardia in ER, and he has done this left total knee replacement, and he was immobilized for the last 5 months. And his heart rate was tend to be 140 beats per minute, and BP is 140 to 80 mmHg. So here's the question for you. So what is the Wells score? Based on the criteria, what would be the Wells score? So, so anyone found the score? So the correct answer is it's 5 to 6, because the heart rate is around 140 beats per minute, which comes around 1.5 score, and he has immobilized for last 5 months, which also scores around 1.5, and he's been presented with the chest pain and tachycardia, shortness of breath, which is also a clinical sign, so it is almost 5 to 6. Okay. So our patient comes under a Wells criteria 5 to 6. So what you will do, you'll just move on to CT pulmonary angiography. So in case if pulmonary angiography is contraindicated, you have to do VQ scan. So when is the angiography is contraindicated? So this is contraindicated when a patient is in CKD or acute kidney injury, where you can't use the contrast medium. So in those conditions, VQ scan should be opted. Okay. So in case if the patient comes with a Wells score of 7, we have to directly start with the anticoagulant without any delay, because he is very much prone to pulmonary embolism. So other investigations are not necessary. If the Wells criteria falls below 4, you could keep this score as a PERC score, which is pulmonary embolism rule out criteria. This as an optional rule. So even here, so you could see the pulmonary embolism rule out criteria where the patient. So if any of this criteria is positive, we have to move for the next treatment protocol. So next step of treatment protocol. So this includes if the patient is more than 50 years, if the pulse rate is more than 100, pulse oximeter, if the saturation is not maintained, unilateral leg swelling, hematopsis, surgery or trauma within 4 weeks, whether DVT or PE or any hormone, oral or any hormone replacement therapy is being used by the patient or not. Okay. So yeah, so we could see that Mr. Cleve falls under the Wells score of 5 to 6, right? So doctor has advised to take CTPA. So CTPA is nothing but the contrast has been sent to your trachea, and occlusion is seen through the imaging. Okay, so through CT scan. So is the CTPA is an ideal choice for Mr. Cleve. So any idea if we have to go for CTPA or any other treatment protocol? Okay. So CTPA is not an ideal choice for Mr. Cleve because Mr. Cleve is an CKD patient. So in CKD patient, you can't use contrast media. So the what will be the ideal choice? So ideal choice will be the ventilation perfusion scintigraphy, the VQ scan. Okay. Fine. So finally, the physician has ordered VQ scan. The scan resulted as pulmonary embolism in the right middle lobe or anterior segment of the right upper lobe. Okay. So from through this scan, we could finally come to a diagnosis that the Mr. Cleve has pulmonary embolism. Okay. This is how the VQ scan looks like. Right. So we'll just complete the treatment protocol. So we are in the Wells score of 5 to 6. So doctor has asked for CT pulmonary angiography, but we suggested to do VQ scan because of his CKD condition, which shows a positive result. So we are going for the treatment protocol for pulmonary embolism. In case if the CT pulmonary angiography is negative, we have to move for age-adjusted D-dimer test. Okay. So if the D-dimer test is likely to be possible, it is by it indicates a bilateral low volume so if it is likely positive, we have to move for bilateral low volume Doppler scan. If the Doppler scan is positive, then we have to treat for venous thromboembolism. If the D dimer is negative, we have to consider it, it has the Mr. Cleve doesn't have any kind of pulmonary embolism. Okay, so we'll move on to this well score of less than 4. As I mentioned before, this is an optional step where the pulmonary embolism rate rule out criteria is an optional step. If it is negative, so we have to consider it as we have to look into other diagnosis. If it is positive, we have to go for D dimer, and again D dimer is negative, same the other diagnosis may be there. So if it is positive, we have to go for CTPA. If CTPA is positive, you have to treat the patient based on the pulmonary embolism suspected. Okay, so other imaging is with echocardiography. So echocardiography is something where you could do in a patient with hemodynamically stable. So normotensive patient with the pulmonary embolism, echo helps to assess the morphology and function of the right ventricle. So here a right ventricle function and morphology is very much important, because in pulmonary embolism, right ventricle gets affected more than left ventricle in the initial stage. Okay, so echo finding used to risk stratify the patient is RV dilation. So as I said before, in the mechanism, once when the pulmonary embolism gets occluded in the pulmonary artery, the vascular resistance increases. When the vascular resistance increases, the RV gets dilated because it does not able to push the blood through the pulmonary artery. Okay, so we have to look for the RVLV diameter ratio. If it is increased, then pulmonary embolism. Hypokinesia of RV. Once when the right ventricle gets dilated, it is hard for the right ventricle to pump the blood. So the kinetic of the right ventricle will be reduced, and we will be looking for right heart thrombi and increased velocity of tricuspid regurgitation. So when the preload increases, the right ventricle gets dilated for after a point. uh, the 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 right ventricle start pushing the blood backward to the right atrium, so where the tricuspid regurgitation can happen. So other biomarkers mentioned over here is right ventricle for right ventricle dysfunction, BNP and NT pro BNP, which has been used, which indicates there is an increased myocardial stretch. If there is an increased myocardial stretch, brain natriuretic peptide and NT-proBNP can be checked for it. In case of infarction in the RV, you could use plasma troponin. Tropi can be used as a biomarker. And other biomarkers include elevated creatinine or decreased GFR because of the decreased perfusion to the kidney, or the D-dimer. So D-dimer is something a product of fibrin formation. So if the myocardium is stretched if the myocardial stretch is increased, we have to go for BNP. If the tropo is positive, it means that infarction is there in the RB. If the D-dimer is positive, then the fibrin has been formed. So D-dimer is something a product of the fibrin formation. Okay, so next is treatment protocol. The basic treatment for pulmonary embolism is anticoagulant. So initially we'll start with parental anticoagulants like heparin, low molecular weight heparin, and fondaparinus for first 10 days, followed by vitamin K antagonist, or alternatively we could go for Novak, like dabigatran or rivaroxaban or apixaban. If rivaroxaban or apixaban is to be started, we have to start within 1 or 2 days of parental heparin. Later, dose can be increased for rivaroxaban in subsequent 3 weeks, and for apixaban in the subsequent 7 days of the treatment. So treatment duration is almost for 3 months, and for longer time outweighing the patient risk of recurrence of bleeding risk. So we'll discuss about the treatment duration in the upcoming slides. Yeah. So the parental anticoagulants include heparin, low molecular weight, and fondaparinux. Heparin is through IV and low molecular weight, and fondaparinux is through subcutaneous route. So high or intermediate risk for pulmonary embolism, we'll definitely start with a parental anticoagulant immediately. So we don't take risk in going with an oral anticoagulant because this has a major action than the oral anticoagulant. So yeah, the next question is once when the pulmonary embolism has been diagnosed for Mr. Cleve. Okay, so the physician wants to start anticoagulant immediately. So what would be the choice of anticoagulant? It's an heparin or a low molecular weight heparin or a fondaparinux. Any guesses? Okay, so it's an heparin. Okay, so why heparin? Heparin is the prime for primary reperfusion. Heparin is the first drug of choice. Okay, and even in the patient with renal impairment, where the creatinine clearance is less than 30 ml per minute, and if the patient is severe obesity, the primary the first drug of choice is heparin. Okay, and it has a shorter half life. It can be rapidly reversed by protamine. That is 1:100 units. So 100 unit of heparin can be reversed by 1 unit of 1 milligram of protamine. Okay, so it can so dosing can be adjusted based on the APTT time. So why not low molecular weight and fondaparinux? So low molecular weight and fondaparinux is little bit contraindicated. So low molecular is little bit contraindicated in patient with the creatinine clearance less than 30 ml per minute, but fondaparinux is totally contraindicated in renal impairment patient. So dosing of enoxaparin is 1 milligram per kg every 12th hourly or 1.5 milligram per kg as a single dose per day, and for dalteparin is 100 units per kg every 12th hourly or 200 units per kg as a single dose. And fondaparinux, it is a selective 10A inhibitors. It's generally administered as an OD dosing, and these two doesn't need any kind of routine monitoring. So, like unlike heparin, these two doesn't have any monitoring parameters, but there's a risk of recurrent BTE and the bleeding in fondaparinux. Right. So we have started heparin for Mr. Cleve, and after 3 days of treatment, heparin INR was checked and it was found to be 1.5. This is the ideal time to start with oral anticoagulant. So when could we start oral anticoagulant? Okay. So if it is an yes, then it's a correct answer. So it's better to start with an oral anticoagulant like vitamin K antagonist immediately once when the INR gets stable. Okay, so when to start oral anticoagulant? Oral anticoagulant or vitamin K antagonist can be started once when the parental is started. This is mainly for vitamin K antagonist. So parental anticoagulant can be withheld when the INR ranges between 2.0 to 3.0 for 2 consecutive days. So you have to take 2 consecutive days reading of INRs, and if the INR is stabilized between 2 to 3, then you can stop your parental anticoagulant and you can continue your warfarin based therapy. Okay. So vitamin K antagonist include warfarin and acinocormarol. So warfarin starting dose is 10 milligram for patient with age less than 60, and if the patient is more than 60 years, you would start with 5 milligram. So daily dose adjustment is made to stabilize the INR. That is around 2 to 3 over 5 to 7 days. Okay, so vitamin K antagonist is an old therapy, but a gold standard one. Uh, but the newer oral anticoagulant therapy has been found, and this has been found very achievable and gives a positive impact. So no, Novax are a smaller molecules when compared with warfarin. This inhibits one of the activated coagulation factors like thrombin. That is factor 2A by dabigatran, and apixaban and rivaroxaban is a factor 10A inhibitors. So less laboratory monitoring is required when compared with vitamin K antagonist. So yeah, so this is an criteria when to choose warfarin and when to choose a direct oral anticoagulant. So generally in adult patient, warfarin is suited. Warfarin can be given with concurrently given after low molecular 5 days of low molecular weight, where where the when the INR gets stabilized. Okay, so in low molecular weight heparin is contraindication only if only warfarin and direct oral anticoagulant is contraindicated in conditions like pregnancies. It can low molecular weight can be suggested. And direct oral anticoagulant, yeah, it can be given for general adult population. So yeah, it can be either rivaroxaban or dabigatran or apixaban. So if you're going to start with rivaroxaban, you can start immediately after parental anticoagulant and after 2 days of parental anticoagulant. If you're going to start with apixaban, same realize about it. If you're going to start dabigatran, you have to start at least 5 days after low molecular weight. In pregnant adults, warfarin and direct oral anticoagulants are contraindicated, but for some certain extent, this can warfarin can be given. But low molecular weight is a drug of choice. In patient with active cancers, warfarin is contraindicated, but low molecular weight and direct oral anticoagulant can be given. If creatinine clearance is less than 30 ml per minute, warfarin can be given, but DOC cannot be given because it gets accumulated in the renal. So it is contraindicated, and low molecular weight can be based on the creatinine clearance. Okay. So what is the duration of therapy? So so we could separate the pulmonary embolism into two types. So one is based on the risk factor, and one is without the risk factor. So if you could be able to see that patient with pulmonary embolism as and any kind of risk factor, you could definitely go with anticoagulant for 3 months. Okay, so anticoagulant for 3 months for patient with pulmonary embolism secondary to transient risk factor. If there is no transient risk factor or the etiology is unknown, you can extend the treatment to extended treatment until any kind of bleeding is being there, or if there's a VT, if there is no recurrence of VT, so you could use until there is no recurrence or any bleeding for the extended treatment. So Novax can be used as extended treatment for pulmonary embolism in patient without cancer also, and risk of bleeding is reduced when compared with vitamin K antagonist. So reduced dose of Novax is considered after 6 months of therapeutic anticoagulant. With this and updates on Novax, we got a few studies which compares the efficacy of different Novax with the standard therapy. So the first one is Recover study, which compares enoxaparin followed by dabigatran versus enoxaparin and warfarin, where the bleeding risk for enoxaparin is 1.6 percentage and for warfarin is 1.9 percentage. And even recover 2 we could see 15 patient with dabigatran, 22 patient with warfarin as a major bleeding risk. So in rivaroxaban we got two studies, Einstein DVT and Einstein PE, where 8.1 percentage of rivaroxaban, 8.1 percentage of warfarin has major bleeding in DVT theory, and in DVT study. In pulmonary embolism study, almost 10.3 percentage under rivaroxaban and 11.4 percentage with warfarin has been seen. In apixaban amplify study, we could see that 0.6 percentage of bleed when compared with warfarin, about 1.8 percentage bleed. So these studies have showed that Novax are non-inferior and it is possibly safer than the standard heparin or low molecular heparin with vitamin K antagonist regimen. Okay, the dosage forms of dose of the anticoagulants has been mentioned over here. So unfractionated heparin, we could give it 80 units per kg IV bolus followed by 18 units per kg per hour infusion can be infused. For enoxaparin, as we discussed, 1 milligram per kg BD or 1.5 milligram per kg OD. Dalteparin is 200 milligram load for 1 month followed by 150 milligram per day subcutaneously for 2 to 6 months. Uh, and for fondaparinux, so maximum per day can go up to 18 units for dalteparin. For fondaparinux, patient with less than 50 kg, 5 milligram OD, 50 to 100 milligram, 7.5 milligram OD, and greater than 100 kg, you must go for 10 milligram OD as subcutaneous route. So initiate warfarin within 72 hours and give concomitantly for at least 5 days. So you have to initiate warfarin within 72 hours of starting this fondaparinus, and you have to use it for at least 5 days to stabilize the INR while using with warfarin. And apixaban is 10 milligram twice daily for 7 days, and rivaroxaban is 15 milligram twice daily for 3 weeks, then 20 milligram once daily at least 6 months. So after 3 weeks, we are going to increase the dose. Same way, for apixaban, it's 10 milligram twice daily for 7 days, followed by 5 milligram twice daily. We are going to change the dose after 5 days. So rivaroxaban should be taken with food to improve the absorption of the drug. So dabigatran, it's 150 milligram BD followed by 150 milligram BD and 110 milligram BD for patient with age 80 years, below 80 years. A dose after 5 days of initial therapy for parental anticoagulant. Reduced dose to 110 milligram BD for patient with age 80 to 8, less than 8, more than 80 years or 75 years with at least one bleeding risk factor. If the patient has one bleeding risk factor with the which follows with the age group, you have to reduce the dose to 110 milligram BD. So once the patient is on these kind of anticoagulant, and if you have to see that the patient has an thrombocytopenia or bleeding risk, you have to go for an antidote. So these are the antidote for the respective anticoagulants. The first one is heparin, protamine sulfate, and for low molecular heparin is also protamine sulfate. Vitamin K antagonist, FPCC and FFP, dabigatran, idarucimab with PCC and APCC. For direct oral factor 10A inhibitors and antizanet alpha with PCC or APCC. For fondaparinus, it's factor 7A with with APCC or antizanet alpha. So these are the anticoagulants used for the patient. So finally, we are done with the case, and Mr. Cleve is finally discharged, and we have managed to extend his lifespan a little more before he dies. Okay. Yeah. So other treatment protocols include thrombolytic treatment. So thrombolytic is thrombolytic restores the pulmonary perfusion. It improves the pulmonary obstruction and decreases the pulmonary vascular resistance more rapidly when compared with unfractionated heparin. So it shows greater benefit if the thrombolytic is being started within 48 hours of the symptoms. In the trial, which is called pulmonary embolism thrombolysis trial, where a normotensive patient with intermediate risk of PE, thrombolysis reduces the significant reduction in the risk of decompensation or collapse of the patient, but this thrombolysis increases the risk of extracranial and intracranial bleeding. So it should be used cautiously. So this is the treatment regimen for thrombolytics. Unfractionated heparin can be administered continuously with activated plasma with RTPA like altiplase, but not with streptokinase or urokinase. So this is an regimen for RTPA. So for uh, for altiplase, it is 100 milligram. Sorry, for a tenecteplase, it is 100 milligram over 2 hours. So this is the regimen for tenecteplase, 100 milligram over 2 hours. For altiplase, it is 0.6 milligram per kg over 15 minutes should be infused. And for streptokinase, it is 250,000 units as loading dose over 30 minutes, followed by 1 lakh unit over 1 lakh unit per hour over 12 to 24 hours. And for urokinase, it is mostly we don't use this urokinase. And thrombolytic is contraindicated in certain conditions where if there is a history of hemorrhagic stroke or any history of ischemic stroke in previous 6 months, central nervous system neoplasm, or any kind of major trauma, surgery, head injury in the previous 3 weeks, or if the patient has any kind of active bleeding, you can't use thrombolytic. This can aggravate the bleeding risk. So thrombolytics are mainly given for a patient with high risk PE. If the patient comes hemodynamically unstable, where the thrombolytics are contraindicated, we have to move for surgical embolectomy as soon as possible. Okay, so surgical embolectomy is indicated when thrombolysis is contraindicated or it is failed. So it is performed in patient with right heart thrombolysis straddling the interarterial spectrum through foramen ovale. So mortality rate is 6% and less has been reported. And the next one is percutaneous method. So recent days we have been moving from open surgery to non-invasive surgeries. So one such thing is percutaneous surgery. So this helps in removal of obstructive thrombi from the main pulmonary artery for the right ventricular recovery. So this can be used in where the patient who has thrombolysis contraindication. So thrombus fragmentation with pigtail or balloon catheter can be done. Rheolytic thrombectomy with hydrodynamic catheter device, suction thrombectomy with aspiration catheters, and rational thrombectomy are the different kinds of interventional options being established for this percutaneous treatment. And the supportive treatment. So supportive treatment includes with the vasopressors. So if when the patient fails in when the patient's RV fails, automatically we know that cardiac output decreases. When cardiac output decreases, totally we'll lose the patient because of hypotension. So in such cases, we can't do volume. We can't load the patient with the volume expansion. So once when the volume is expanded, a venous return, that is preload will increase. So when the preload increases, it leads to even more dilation of RV, and this can even worsen the condition. So in such conditions, we could use vasopressors or inotropes. So we have norepinephrine to improve the RV function via positive inotropic effect and improves the RV perfusion by alpha receptor stimulation. It also increases the blood pressure and use is confined only to hypotensive patient. If the patient has hypotensive, we will use only norepinephrine. And dobutamine dopamine, as we all know, this acts only in the beta receptors and it increases the heart rate. So it is considered only where there is a low cardiac index and normotensive patient. And raising cardiac index over normal is done by dobutamine. Um, so epinephrine has action of both norepinephrine and dopamine, which has action of in both alpha and beta receptors. If the patient has a low heart rate with reduced blood pressure, you could use epinephrine. So, so we have seen about the vasopressors. So now it comes to ventilators. As we saw the pathophysiology, the patient might go for hypoxemia and hypocapnia. So for hypoxemia, it can be reversed by oxygen administration. In this situation, we have to make sure that the patient doesn't go for positive intrathoracic pressure. If the patient goes into positive intrathoracic pressure, the venous return will be decreased. This can also worsen the RV failure. Okay, so this is some scale. This is called PESI scale. Here we have the PESI scale. So this is a PESI monitorings, which shows the points for patient with these parameters. So we'll differentiate the pulmonary embolism into high risk, intermediate risk, and low risk. So intermediate can be differentiated into intermediate high risk and intermediate low risk. So with the PESI score, if the patient is on shock or hypotension, with the PESI score of PESI class of 3 to 5 and signs of RV dysfunction with cardiac laboratory biomarkers positive, the patient is considered as an high risk patient. So we'll either move for thrombolysis. If the thrombolysis is contraindicated, we'll go for embolectomy. If embolectomy cannot be done, we will go for percutaneous catheter treatment. And the next one is intermediate. So intermediate classified into intermediate high and intermediate low, where shock is not present. No, shock is not present, but the patient falls under PESI class 3 to 5 with signs of RV dysfunction, laboratory markers as positive, or either one of those things is positive. We'll segregate them as a high and low risk. And in the low risk, both shock and the patient is not in hypotensive and the PESI class and doesn't falls under any PESI class ranges from 3 to 5, and any other assessment is optional for, and even laboratory biomarkers and RV dysfunction is negative for the patient. The patient falls under low risk PE. Okay, so as I discussed, the pulmonary embolism with shock with where the patient is considered as high risk PE, we have to so we'll check for hemodynamic, and we have to give hemodynamic and respiratory support followed by unfractured heparin, or thrombolysis can be done. If thrombolysis is contraindicated, we'll go for surgical embolectomy or percutaneous catheter directed treatment will appropriate. If the patient falls under intermediate or low risk, we'll start with low molecular heparin or fondaparinux subcutaneously unless no renal dysfunction. If there is any renal dysfunction, we'll go for heparin. And for low risk patient, we'll discharge as soon as possible, and we'll switch to oral therapy. If it is an intermediate high risk patient, we'll go for thrombolysis or surgical embolectomy or percutaneous catheter. If it is a intermediate low risk patient, we'll directly start with an anticoagulant. So this is an overall therapeutic strategy. So if the patient is suspected to be suspicion for pulmonary embolism, we'll look for shock or hypotension. If there's a shock, we'll go for diagnostic algorithm, and the patient is high risk, we'll go for primary reperfusion. If the shock doesn't present, we'll go for PESI scale. With the PESI scale, we'll say that the patient is intermediate risk or a low risk. If he is a low risk, we'll start on oral anticoagulant. Sorry, initially with parental anticoagulant and discharge with an oral anticoagulant. If the patient is on intermediate risk based on a laboratory testing and the RV function, we'll tell whether the patient is on intermediate high risk or low risk. If the patient is on high risk, we'll start with anticoagulant or we'll do thrombolysis or we'll do embolectomy, and we'll monitor the patient. If the patient is on intermediate low risk, we'll hospitalize the patient for a few days. We'll give the anticoagulants, IV anticoagulants followed by oral anticoagulants. We'll monitor and then we'll discharge the patient. So takeaway points. Mainly the knowing the past medication history or a medical history is very much important. As we saw in our case, Mr. Cleve, my friend who has an TKR and he was immobilized. So immobilization history is very important in that case, and presenting complaint is important. And all shock does not require volume correction, which is very much important for obstructive shock. Obstructive shock is where if you're going to correct through volume, it worsens the condition. And starting the anticoagulant or thrombolytics is a key role in the treatment, and switching and length of treatment is very much important. You can't extend the treatment for in patient with high risk bleeding, and you can't stop the treatment within 3 months if a patient has a risk of recurrent VTE. So these are my references. And the following topic is by the Infectious Disease Forum, inhalation antimicrobials, mechanical ventilated patient by Saidullah on 18th May, and followed by de-escalation and escalation of antibiotic by Radhika on 19th May. And antimicrobial dosing in renal and hepatic impairment by Aisha on May 20th. Rapid sequence intubation by Harita by May 23rd. Antimicro loading dose and maintenance dose concept by Saidullah on May 25th. And basic of evidence-based medicine by Mohammed Rashid on May 27th. Antibiotic intravenous to oral switch by Haria on May 30th. Yeah, that's all the presentation, upcoming presentations, and thank you.
Thank you, Vishwapal. I think so. It was a very informative presentation on how you took things for the obstructive shock, the detailed physiology, and how to go on with the diagnosis and the management in a very protocolized manner. I think so. It was very well presented. And just like, take key away points that you said, that patient history is very important in knowing whether it is a PE or any other DVT, whether any evidences of surgery or any stasis. So, like, I would like to ask you a couple of things, like being a critical care clinical pharmacist, sure, you'll be taking the patient's history, but apart from there, when you see a case of patient with PE, what will be your roles, or what were your roles in the management of such a patient?
First of all, thank you, and it's a great question, I guess. So, in patient with PE, from the clinical pharmacist, we'll look for the platelet counts, once after starting the anticoagulants. And if based on the anticoagulants, we'll be looking for the proper diagnostic. Like if, for example, if it is an heparin, we'll monitor APTT. If it APTT goes higher, we'll definitely have to stop the treatment, or we have to look for any or we have to reduce the dose if we can't able to stop the treatment. And while switching to oral therapy, if the patient, if we have to give start with vitamin K antagonist, definitely we have to check for INR, and we have to stabilize the INR before the patient gets discharged. Hello.
Am I audible, Rishabha?
Yeah, audible now.
Yeah, I think so. Very well answered. So saying the what are the roles, I think so exactly monitoring of the therapy is very crucial, and I think so all clinical pharmacists can take a active role in the said task. Another question that I would like to ask is what kind of a choice when it comes to the selection of therapy? I think so where we can play a crucial role. So, what according to what factors will you consider for choosing which thrombolytic or which NOACs for the treatment?
Yeah, so this is a wonderful question. So even I had some doubts in it. So got cleared by looking into some guidelines, and finally got the answer for it. Where in patient with renal failure, or a patient who's pregnant, you could go for warfarin therapy, warfarin based therapy. And the patient, if a patient is a onco patient or cancer patient, you can't start with warfarin. At least you could go with low molecular weight heparin or and Novak. So in the Novak, there's a dispute where there's a difference between all the three Novaks, like when to use dabigatran, when to use apixaban, and when to use rivaroxaban. So we got certain parameters, certain things to look after. So Novaks are totally contraindicated in renal failure. So you can't use Novaks in a renal failure patient. And when you're moving to dabigatran, so if the patient has any kind of mucosal bleeding, or if the patient has any ischemic stroke, or if a patient has heart failure with the risk of pulmonary embolism, or a patient presented with pulmonary embolism, you can use dabigatran. So these are the three conditions for dabigatran. For apixaban, for apixaban, if the patient has any GI bleeding, if the patient has any GI bleeding, other than GI bleeding, you can't. If the patient is only confined with GI bleeding like peptic ulcer, so you could use apixaban. It's a drug of choice in the GI bleed case. And for the rivaroxaban, it can be used in ACS patient, acute coronary syndrome patient. And even this apixaban and rivaroxaban can be used in patient with creatinine clearance less than 30 ml per minute. So you can't use it more than if the creatinine is less than 15 ml, but considerably you can use from 15 to 30 ml. Rivaroxaban and apixaban can be used in those patients. And with the thrombolytics, there are three types of thrombolytics where we can classify into three generations: first, second, and third generation. For the first is streptokinase. So you can't use streptokinase because of the allergic reactions what it produces. And other cases where the risk of bleeding is very high and it is less fibrin specific. And when moving to second generation, it is an uh, altiplase. Altiplase, it needs 2 hours of administration. It takes 2 hours for 100 milligram of altiplase to be administered. Sorry, to 100 milligrams to be administered, and it has a risk of bleeding too. But when you compare with tenecteplase, it is more fibrin specific and can be administered in a bolus. Can be administered within 5 to 10 minutes. And when compared to others two things, the risk of bleeding is very low with tenecteplase.
Correct. I think so. One needs to jot down all those pharmacologic changes, kinetic changes, or the dynamic changes that the drug will impose to the patient, and what kind of certain conditions that the patient is already having, and how it will interplay with the patient. And obviously, the how fast we can give the drug also matters a lot here, as
Yeah,
quick as possible.
pharmacokinetics and dynamics matters a lot, and
Yes.
that's where we play the major role, I guess. So as a clinical pharmacist, we have to look for all the kinetics and dynamics part to improvise the patient's outcome.
Yes, very true, very true. Just one last question, I think so. This will be a very important one also for the audience out there, who will be asking like, we need to switch IV to oral. In a normal patient, it's okay, you can switch, there's no issues. But what kind of factors that you will be looking into switching for a critically ill patient and when there are a lot of complications? So what are factors that you look into prior to, switching or making a recommendation for IV to oral switch of the anticoagulants?
One such factor is the patient should be hemodynamically stable. So that's a major factor. So once the patient is hemodynamically stable, you could start with oral anticoagulant simultaneously, and you could taper the IV anticoagulant, and slowly you can continue with your oral anticoagulant for next 3 months, or however the doctor says, however the physician orders, based on the patient's condition. So I guess the hemodynamically, if the patient gets stabilized, then it's fine to switch to oral anticoagulant.
Okay. Thank you so much, Vishwapal, for the lovely presentation. And
Thank
good evening to all the audience for being patient listener and good evening. Yeah. Thank you.